Welcome to the Funnel Effect. Today we're doing a really deep dive into something called renal denervation, or RDN. It's an interventional therapy that's definitely making waves in how we manage chronic diseases. Our discussion is based on a fantastic state-of-the-art review. It's titled Renal Denervation in Hypertension and Chronic Heart Failure. And the authors are Lucas Lauder, Naomi D.L. Fisher, Michael Boom, Otmar Feaster, Eric A. Sisemski, Pam R. Taub, and Felix Mafode. Quite a lineup. So our mission here is to really unpack RDN. It's this catheter-based approach, pretty cutting edge, that goes after the sympathetic nervous system, the goal, managing hypertension and potentially other cardiovascular issues too. And the really key angle, I think, is that this treatment works whether or not you, the patient, actually remember to take your pills every day. It's like having an always-on system, which is huge in a world where getting people to stick to their medication is, well, a massive challenge.
Oh, absolutely. That idea of an adherence-independent therapy, that's precisely what we need. Uncontrolled hypertension. People don't always grasp the scale. It's not just common. It's literally the #1 global risk factor for cardiovascular disease. And the review highlights something pretty stark. The global prevalence has actually doubled in the last 30 years.
Yeah,
Doubled.
Doubled. That's staggering. Really means we're losing ground, doesn't it?
Yeah.
Even with all the good, cheap medications available. And that failure to control it clinically. It's an economic nightmare, too. We're talking, what, nearly $250 billion a year? The source mentioned $219 billion just in the U.S. back in 2019.
Exactly, $219 billion. And that figure, it doesn't even fully capture the cost of the strokes, the heart attacks, the kidney failure that stem from it. It's a tidal wave economically.
Wow.
And the frustrating part is we have the tools. ARBs, diuretics, calcium channel blockers, they work, they save lives. But the single biggest barrier, the thing that stops us getting long-term control for hypertension, and also for things like chronic heart failure or CHF, it's patient non-adherent.
Right. Non-adherence. Sounds simple, maybe like just forgetting sometimes.
Yeah.
But the stats you pull from the sources show it's much more than that. We're talking adherence rates hovering around 50% for people with uncontrolled high blood pressure.
Yeah, that 50% figure from observational studies is, well, it's a disaster, frankly. But we need to break down non-adherence a bit. There's primary non-adherence first. That's when someone gets a prescription but never actually fills it or starts taking the drug. The rates for that alone are somewhere between 5% and maybe 24%.
So up to a quarter of people don't even start.
Right. Then you've got secondary non-adherence. That's where people start the medication, but then they stop, or they don't take it regularly, or they lower the dose themselves. That's where you see adherence drop towards that 50% mark for a lot of these chronic conditions.
And if a treatment only works half the time because of behavior, you just can't control something like hypertension across the population. But the thing that really jumped out at me in the review was the data around so-called resistant hypertension.
Ah, yes. That data is so important because it basically revealed a huge diagnostic blind spot. You have these patients labeled as having resistant hypertension. Their blood pressure stays high even though they're supposedly on 3, sometimes more, different types of blood pressure pills, including a diuretic.
Okay, so you'd think their body just isn't responding to the drug.
That's what everyone thought.
Yeah.
But then researchers used the gold standard test toxicology analysis, using mass spectrometry to actually check for drug metabolites in the patient's blood or urine. And in this group, this supposedly resistant group, the non-adherence rates were anywhere from 23% right up to 66%.
66%. So potentially 2/3 of the people thought to be biologically resistant just weren't taking their medication properly.
Exactly. Or maybe not taking it at all. It means a huge amount of clinical effort, escalating drug regimens, adding more pills. It might have been completely misdirected.
We were treating physiology when we should have been addressing behavior, compliance.
Precisely. It's often called pseudo-resistant hypertension, and it completely changes the game. It means an interventional approach like RDN, one that targets the disease pathway directly, bypassing that need for daily pills. It's not just a nice idea, it could be essential for getting control in a really large, high-risk group.
Okay, so if non-adherence is such a core problem, what's driving it? Is it just that the drugs are too expensive?
Cost is definitely a factor. Affordability, especially if you need multiple drugs for different conditions.
Yeah.
It's a big socioeconomic driver for sure. But it's not just cost. Therapy-related issues are huge too. Think about side effects. A lot of blood pressure meds can cause fatigue, dizziness, even sexual dysfunction. People understandably might just stop taking them.
Right. Or complex regimens.
Yeah.
Having to take pills multiple times a day.
Yeah, that makes it harder to stick with. And then there's something sort of unique to hypertension.
The fact that you don't feel sick.
Exactly. It's largely asymptomatic, right?
Mhm.
Until something catastrophic happens, like a stroke or a heart attack. So the patient's own belief, I feel fine, why do I need this pill?
Mhm.
That's a really tough barrier to overcome.
Mm.
And then you have health system factors, too. Maybe communication isn't clear, maybe follow-up isn't good enough. It all adds up.
It paints a clear picture of why something like RDN is so appealing. It sidesteps all those behavioral hurdles.
Ah,
Okay, let's shift from the behavioral problem to the biological solution RDN offers. The review makes it really clear that the core idea, the reason RDN might work for both hypertension and heart failure, is the same. It's all about targeting an overactive sympathetic nervous system, the SNS, and also hitting the brakes on the system it triggers, the renin-angiotensin-aldosterone system, or RAAS.
That's the common thread, sympathetic overactivity. Now, acutely, if you're stressed or in danger, that SNS activation is crucial. It keeps your heart pumping, keeps you going. But in chronic diseases like hypertension and heart failure, the problem is this system gets stuck in the on position. It's prolonged activation. And that constant overdrive is really damaging. It leads to what we call maladaptive remodeling, basically, scarring and thickening in the blood vessels, the kidneys, and the heart muscle itself.
So if the SNS is stuck on go, how does RDN specifically intervene? The review really centers on the kidney's role.
Yeah, the kidney is kind of ground zero here. Its function is just so tightly linked to sympathetic tone. You've got these sympathetic nerve fibers that run right alongside the renal arteries heading into the kidneys. And importantly, these nerves carry signals both ways.
Okay, so efferent nerves carrying signals out from the brain to the kidney, and afferent nerves carrying signals back from the kidney to the brain. Let's start with the efferent ones, the output. What happens when they're chronically activated?
Okay, the efferent nerves, when they're firing too much, do three main things that mess up the system. First, they trigger the release of renin. That happens via beta-1 receptors on specific cells in the kidney, the juxtaglomerular cells. And renin, of course, is the starting gun for that whole RAAS cascade.
Right, the system that ultimately leads to angiotensin II and aldosterone.
Exactly. Second, these efferent nerves directly tell the kidney tubules to reabsorb more sodium. That's via alpha adrenoceptors. So the kidney holds on to salt and water, increasing your blood volume, increasing blood pressure.
Okay, renin release, sodium retention. What's the third?
Third, they cause vasoconstriction within the kidney itself. They clamp down on the small blood vessels, reducing overall renal blood flow. That contributes to kidney damage over time.
So efferent nerves are driving fluid retention and kicking off the RAAS. But you said there are efferent nerves 2 signals going from the kidney back to the brain. This sounds like a feedback loop.
It absolutely is. And this afferent pathway might be key to RDN's more systemic effects. These are sensory nerves. They basically monitor the kidney for signs of trouble injury, lack of oxygen, ischemia, or increased pressure within the kidney. When these afferent nerves detect problems, they send alarm signals back up to the central nervous system, mainly the brainstem.
And the brain interprets these signals as, what? A threat.
Essentially, yes. The brain interprets this as a signal that something's wrong, and the response is to ramp up sympathetic outflow globally. It's like the kidney is telling the brain, hey, things are bad down here, crank up the defenses.
And globally means not just affecting the kidneys anymore.
Correct. The increased sympathetic tone goes everywhere. The brain sends stronger signals out to the heart, increasing heart rate, making it pump harder, to the lungs, and, critically, to the peripheral blood vessels all over the body, causing them to constrict.
Ah, so the kidney itself, when it's under stress, can actually trigger a process that raises blood pressure throughout the entire body.
Precisely. It's a vicious cycle. The diseased or stressed kidney signals the brain, and the brain makes the hypertension worse systemically. And this is where RDN gets really interesting. By ablating or destroying these nerve fibers around the renal artery, both afferent and efferent, you're potentially breaking that cycle.
Okay, so that's the big difference compared to just taking pills. Most drugs block something downstream, right? They block angiotensin or calcium channels.
Exactly. They deal with the consequences. RDN aims to modulate the signals at the source. It reduces the efferent drive to the kidney, lessening renin release and sodium retention locally, and it reduces the afferent signals from the kidney to the brain, calming down that global sympathetic overdrive. It's hitting the problem higher up the chain.
Which then has knock-on effects on the RAAS system.
Definitely. Less renin release means less angiotensin II, less aldosterone, and that's crucial because those hormones, when chronically high, are major drivers of that damaging fibrosis and hypertrophy in the heart, kidneys, and vessels. Interrupting the RAAS is key to preventing organ damage.
The review also mentioned something intriguing about natriuretic peptides. the body's natural good guys in this system. RDN seems to boost them. How does that work?
Yeah, that's a really interesting, more subtle effect. Natriuretic peptides are beneficial hormones. They do things like dilate blood vessels, help excrete sodium and water, basically. They counteract the bad effects of the RAS.
Okay.
Now, normally, these helpful peptides get broken down pretty quickly by an enzyme called neprilysin. What some studies suggest is that RDN actually reduces the activity of this neprilysin enzyme.
So RDN stops the breakdown of the good hormones.
It seems to augment their bioavailability, yes. By lowering neprilysin activity, RDN lets these beneficial natriuretic peptides stick around longer and do their job more effectively. So you get this kind of 1-2 punch. You're dialing down the harmful sympathetic RAS drive, and you're boosting the body's own beneficial counter-regulatory system. More vasodilation, more fluid excretion, less stress on the heart wall. It's quite elegant, really.
It is. And, targeting nerves to lower blood pressure sounds really modern, but you pointed out in the source material, this isn't a totally new idea. There's some history here with surgical sympathectomy.
Oh, absolutely. We have to acknowledge that history. Back in the 1940s, 1950s, before we had good pills for severe hypertension.
Which must have been terrifying back then.
Life-threatening. So surgeons would actually perform sympathectomies. They'd surgically cut or remove parts of the sympathetic nerve chain in the chest or abdomen.
And did it work? Did it lower blood pressure?
It did lower blood pressure, often dramatically. But the side effects, they were brutal.
How bad are we talking?
Really debilitating. Severe orthostatic hypotension patients would faint just standing up, problems with bladder control, bowel function, high rates of impotence in men. Plus, the surgery itself was major, carried significant risks. High morbidity, even mortality.
So effective, but at a terrible cost.
Completely unacceptable by today's standards, which is why, as soon as the first effective and relatively safe oral medications came along in the 60s, surgical sympathectomy basically disappeared overnight.
Right. So modern RDN is really the precision-guided evolution of that original concept, right?
Yeah.
Targeting just the renal nerves minimally invasively without those systemic side effects.
Exactly. It's taking that core insight, the role of the sympathetic nerves, and applying it in a much safer, much more targeted way using catheter technology.
Okay, that history really sets the scene for the modern tech. Let's get into the nuts and bolts of how RDN is actually done today. It's catheter-based, minimally invasive. The review outlines 3 main ways to ablate those nerves: using radiofrequency, RF energy, using ultrasound energy, or injecting a neurolytic agent like alcohol. And 2 systems just got FDA approval in late 2023, the Paradise system using ultrasound and the Simplicity Spiral using RF. So these are clinically relevant now.
They are. And the differences between RF and ultrasound, they're not just trivial. They reflect different strategies for tackling the key anatomical challenge: getting the energy to the nerves effectively. Remember, the nerves aren't just wrapped neatly around the artery. They're in the outer layer, the adventitia.
And the review had that figure 1 showing the nerve distribution isn't uniform, right? They tend to bunch up in certain areas.
Precisely. Histology studies show the nerves come in from various places and then sort of converge towards the artery. The highest density of nerves, and the point where they're closest to the inside of the artery, the lumen, tends to be further down, in the distal part of the main renal artery, and especially in the branches after the artery splits.
Okay, so targeting those distal segments in the branches is crucial for getting a good result.
Absolutely critical. If you only treat the main proximal part of the artery, you might only hit 50% or 60% of the total nerve fibers. That's likely not enough for a robust effect. You've got to go distal, into the branches.
So how do the different technologies manage that? Let's start with RF, like the Simplicity Spiral system. How does it target distally?
RF systems typically use a catheter with multiple electrodes, often arranged in a spiral or helical shape. This lets the operator deliver energy at several discrete points along the vessel wall. Because the catheter is often flexible and steerable, they can navigate it into those distal segments and even into the larger branches to apply the RF energy there.
And the depth of the burn matters too, right?
Critically, the Simplicity Spiral system, for instance, creates lesions with a mean depth of about 3.8 millimeters. That's deep enough to reach over 90% of the nerve fibers if you're treating in those distal segments and branches where the nerves are closer.
Okay, so RF offers flexibility to chase the nerves into the branches. How does the ultrasound approach, like the Paradise system, differ?
Ultrasound takes a different tack. It uses a balloon catheter placed in the main renal artery. When activated, it delivers ultrasound energy circumferentially in a 360-degree pattern, heating the tissue all around. The energy penetrates quite deep, anywhere from 1 to 7.5 millimeters. So the idea is you can treat the main artery effectively without needing to maneuver into the smaller, often trickier branches. It's potentially simpler and faster.
Simpler, maybe, but what's the catch? You mentioned nerves don't always follow the main highway.
Right. The potential downside for ultrasound is the issue of late-arriving nerves. Anatomy studies show that a significant portion of the nerve supply, maybe up to 60% in some people, doesn't run neatly alongside the main renal artery. These nerves might join the artery further down or run alongside it, but slightly separate.
So if the ultrasound is only treating the main artery,
It might completely miss that substantial chunk of nerve fibers that arrive late or run parallel. That could limit the overall effectiveness of the denervation. It's a trade-off. Procedural ease in the main artery versus potentially missing some targets.
interesting. Now, both RF and ultrasound rely on heat, and the review mentions a challenge common to both.
Yeah.
The heat sink effect. What's that about?
The heat sink. It's a really practical problem in thermal ablation. Basically, any nearby structure that can draw heat away from your target can reduce the effectiveness of the burn. Think about blood flowing through the artery itself, or large adjacent veins, lymph nodes, even dense scar tissue or calcified plaques within the artery wall.
So these structures act like radiators, pulling the heat away before it can cook the nerves.
Exactly. They dissipate the thermal energy. So even if you're delivering enough power, the actual temperature reached at the nerve location might not get high enough, you generally need 60, 70 degrees Celsius, to reliably destroy the nerve tissue.
Which means the effectiveness could vary a lot depending on the individual patient's anatomy and plaque burden.
Precisely. It introduces variability, which brings us to the third approach,
Hmm.
neurolysis, using something like alcohol injection. This is non-thermal.
Right, like the Peregrine system mentioned. How does injecting alcohol get around the heat sink problem?
Well, instead of relying on heat, it uses a chemical agent, alcohol, to destroy the nerves. The system uses fine needles that deploy from the catheter through the artery wall into the perivascular space, the tissue surrounding the artery where the nerves live. It then injects a small amount of alcohol directly into that space.
So it's targeting the nerves chemically from the outside in almost.
Kind of. And the theory, supported by preclinical work, is that this chemical ablation is less affected by those thermal heat sinks. The alcohol permeates the tissue and kills the nerves chemically, regardless of nearby blood flow or plaque. It might offer a more consistent nerve kill radially around the artery.
Fascinating. 3 different ways to achieve the same goal. But regardless of how you ablate the nerve's heat or chemical you mentioned earlier, that hitting those afferent pain fibers can hurt. This makes patient comfort during the procedure really important, doesn't it?
Absolutely non-negotiable. It's not just about the patient having a bad experience. If the ablation is painful, the patient is going to move, even small movements. And if the patient moves while you're trying to deliver energy precisely to a millimeter-specific target, you risk incomplete ablation, or worse, hitting something you shouldn't, like damaging the artery lining.
So good pain control isn't just nice to have, it's actually crucial for the technical success of the procedure.
Totally. Adequate analgesia and usually deep sedation are critical. It ensures patient comfort, keeps them still, allows the operator to be precise, and ultimately likely improves the chances of a successful clinical outcome. It's a key quality measure.
Okay, let's talk about how well RDN actually works for hypertension. Its journey wasn't exactly smooth. You mentioned that first big sham-controlled trial, Simplicity HTN-3, back in the mid-2010s.
Yeah.
It failed, right? That caused a lot of death.
It did. HTN-3 failed to meet its primary efficacy endpoint. And yeah, that put a real damper on things for a while. People were very skeptical.
But the review explains why it likely failed. And it wasn't necessarily the technology itself.
Exactly. Looking back, HTN-3 had some significant design flaws. A big one was probably unrecognized non-adherence. They didn't rigorously check if patients were actually taking their background medications. It's quite possible many patients in the RDN group felt treated and maybe slacked off on their pills, which would obviously mask any real effect of the denervation itself.
And they relied mostly on office blood pressure readings.
Yes, which we now know can be really unreliable. The white coat effect is real. A single snapshot in the doctor's office doesn't give you the full picture.
So the second wave of trials learned from this. They used better methods.
Much better. The second-generation sham-controlled trials, like Spiral HTN on med, Spiral HTN off med, Radiance HTN solo, Radiance 2, they incorporated crucial improvements. They used 24-hour ambulatory blood pressure monitoring, ABPM, as the primary endpoint. That gives a much more accurate real-world measure of blood pressure control.
Right, measures it while you're living your life, sleeping, etc.
Exactly. And crucially, they implemented strict adherence monitoring, often using urine or blood tests to confirm patients were actually taking their prescribed background meds.
And when they use these better methods,
The results became much clearer and remarkably consistent. These newer trials consistently showed that RDN was both safe and significantly more effective than a sham procedure at lowering blood pressure.
okay, let's get to the numbers. What kind of blood pressure drop are we actually seeing on average based on the meta-analyses?
When you pull the data from these rigorous sham-controlled trials, RDN leads to an average reduction in 24-hour systolic blood pressure of about 4.4 millimeters of mercury compared to sham. And for office systolic BP, the reduction is a bit larger, around 6.6 millimeters of mercury. Diastolic BP drops followed a similar pattern.
4 to 6 points. Now, someone listening might think, is that really enough to justify a procedure compared to just adding another cheap pill? How significant is that reduction clinically?
That's the million-dollar question, isn't it? And context is everything. First, even a few millimeters of mercury sustained over time makes a big difference at a population level. We know from huge epidemiological studies that even a 5 millimeter Hg sustained reduction in systolic BP cuts the risk of major cardiovascular events like stroke by about 13%, heart attacks by 10%. So 4.4 millimeter Hg isn't trivial. It translates to meaningful long-term risk reduction.
Okay, so the number itself matters. But you also mentioned earlier this always-on effect. That seems like a key advantage over pills.
It really is. Think about medication. You
Right.
take a pill, it gets absorbed, it works, then its effect wears off over 12 or 24 hours. If you miss a dose or even take it late, your coverage dips. RDN, once done, provides a continuous 247 background reduction in sympathetic tone and blood pressure. It's always working.
And that's especially important during vulnerable times.
Exactly. Like those early morning hours between maybe 4 a.m. and 10 a.m., that's when the risk of heart attack and stroke peaks, partly because medication levels from the previous day might be at their lowest ebb. RDN provides constant protection during that critical window. It smooths out the peaks and troughs.
Still, the review mentions response variability. Not everyone gets the same benefit, right? About 2/3 respond.
That's about right. If you define a responder as someone who has at least a 5 millimeter Hg drop in their daytime ambulatory systolic BP, about 60% to 70% of patients in the trials met that threshold. So, yes, there is variability. A significant minority don't get that level of response. And honestly, apart from knowing that people with higher baseline BP tend to respond better, we don't have great ways yet to predict who will be a super responder versus a non-responder. That's a major area for ongoing research.
It's really important to stress RDN isn't usually a cure for hypertension, right?
Right.
Most people still need meds.
Absolutely vital point. For the vast majority of patients, RDN is an adjunctive therapy. It's something you add on top of lifestyle changes and medications. In the trials, even after successful RDN, somewhere between 70% and 80% of patients still needed to take at least some blood pressure medication to reach their target goals. RDN helps get them there, often with fewer pills or lower doses, but it rarely eliminates the need for meds entirely.
What about durability? You burn the nerves?
Mm.
Do they grow back? Does the effect wear off after a year or two?
That's obviously a critical question. The long-term data looks pretty good, actually. It's tricky to study perfectly because you can't ethically keep a sham group going for 5 or 10 years. People need treatment. But if you look at long-term follow-up from the big registries, like the Global Simplicity Registry, and extended follow-up from trials like HTN-3 and the Spiral studies, they show the blood pressure lowering effect is sustained for at least 3 years.
3 years is pretty solid.
It is. And some smaller single-center studies, though less robust, have suggested the benefit might even extend out to 10 years. So while nerve regeneration is theoretically possible, the clinical effect seems durable for a meaningful period. The consensus is it's a long-lasting intervention.
Okay, efficacy seems established. Durability looks promising. What about safety? You contrasted it with the old surgical approach, but any procedure has risks. How safe is modern RDN?
The safety profile is actually remarkably good. That's been a consistent finding across all the major sham-controlled trials. When you look at serious procedural or vascular complications, things like damage to the renal artery, dissection, perforation, significant bleeding, the overall rate was very low, around 0.5%. And importantly, there was no significant difference in these complication rates between the patients who got RDN and those who got the sham procedure.
What about long-term effects on the kidney artery itself, like causing narrowing or stenosis?
That was a major theoretical concern early on, but it hasn't borne out. Follow-up imaging hasn't shown any increased risk of renal artery stenosis. And importantly, there's been no difference in kidney function decline as measured by eGFR between the RDN and sham groups over time.
So the main risks are basically the standard ones for any catheter procedure.
Pretty much. You have a very small risk, less than 1% of complications at the access site where the catheter goes in, usually the groin. And there's the exposure to contrast dye and X-ray radiation, which comes with any endovascular procedure. But overall, it's considered a very safe intervention in experienced hands.
And this strong safety and efficacy data has paved the way for RDN to actually be included in clinical guidelines now, right? Especially in Europe.
Yes, that's been a major step forward recently. The European Society of Hypertension, the ESH, updated their guidelines in 2023. They now recommend RDN as a valid treatment option for patients whose blood pressure isn't controlled despite taking their prescribed medications. And they specifically mention it for patients with confirmed resistant hypertension, but also importantly for patients who genuinely can't tolerate the side effects of medications or whose quality of life is really poor due to complex drug regimens.
So ESH is quite positive. What about the European Society of Cardiology, the ESC? They tend to be a bit more conservative generally?
They are slightly more cautious, yeah. Their 2024 perspective is that RDN may be considered. They highlight two main groups. First, patients with proven resistant hypertension. But interestingly, they also open the door for patients with uncontrolled hypertension who are on fewer than 3 drugs if they also have a high overall cardiovascular risk profile and they express a preference for the procedure. So not just for resistant cases, but selected high-risk individuals earlier on.
Okay. And how does the U.S. perspective compare? What's the American Heart Association saying?
The AHA issued a scientific statement. They endorse RDN as an adjunctive treatment, again, emphasizing it's usually added to meds and lifestyle. They suggest prioritizing patients with resistant hypertension and those at high overall cardiovascular risk. And very importantly, they specifically include patients who have documented difficulties adhering to or tolerating medical therapy. So they directly acknowledge that adherence challenge we talked about as a key reason to consider RDN.
That makes sense. Are there any major contraindications or limitations mentioned in the guidelines based on who was studied in the trials, like kidney function?
Yes, that's a key one. Because the major trials generally excluded patients with severe chronic kidney disease, the guidelines reflect that. In Europe, the recommendation is generally to limit RDN to patients with an estimated glomerular filtration rate, or eGFR, of at least 40 mmol/min 1.73 meters of Therafols. In the U.S. guidance, it's often cited as an eGFR of at least 30.
So you need reasonably good kidney function to be eligible.
Right. You need to ensure the kidneys aren't already severely damaged and the renal arteries are suitable for the procedure.
Okay, let's pivot now to chronic heart failure, CHF. The review makes a strong case that the underlying reason RDN might work here is compelling, maybe even more so than for just hypertension alone. Why is that?
Because heart failure is, almost by definition, a state of profound sympathetic nervous system overdrive, even more so than in typical hypertension. If you measure things like norepinephrine spilling out from the kidneys or direct nerve activity in muscles, the levels are often significantly higher in patients with CHF. And we know this chronic, intense sympathetic activation in heart failure is really bad news. It directly damages the heart muscle, promotes arrhythmias, depletes the heart's own adrenaline stores, and it's strongly linked to worse outcomes, more hospitalizations, higher mortality.
And hypertension itself is a huge stepping stone towards heart failure, isn't it?
Massive. Untreated or poorly controlled hypertension dramatically increases the lifetime risk of developing heart failure. It's something like double the risk for men and triple the risk for women with hypertension compared to those with normal blood pressure.
So the theory is strong. Tackle the sympathetic overdrive with RDN, maybe you can help heart failure patients or even prevent it. But what does the actual clinical evidence show so far? Especially for HFrEF heart failure with reduced ejection fraction.
Yeah, despite that compelling rationale, the hard clinical evidence for RDN in heart failure is still pretty thin, especially from large, robust trials. For HFrEF, the review points out there have only been about 6 small randomized trials published. They were quite varied in design, patient populations, and in total, they only included around 100 patients who actually got the RDN treatment.
Only 100 patients across 6 trials. That's really small.
It is. And unsurprisingly, with such small numbers and heterogeneity, the results have been mixed. Some showed hints of benefit, others didn't. It's just not enough data to draw firm conclusions for HFrEF yet.
Were there any specific positive signals, even if small?
Well, one small pilot study, the RH pilot, was mentioned. It only had 7 patients, a mix of reduced and preserved ejection fraction. Interestingly, they didn't see big changes in BP or heart rate, which maybe isn't surprising as these patients are often already maxed out on heart failure meds. But all 7 patients reported feeling better symptomatically. And on average, they could walk about 27 meters further in a 6-minute walk test after 6 months. That hints at a potential improvement in functional capacity and quality of life, even without major hemodynamic shifts. But again, tiny numbers.
Okay, so HFrEF is still very much investigational. What are the other major type of heart failure? HFpEF heart failure with preserved ejection fraction. This is the one where we desperately need better treatments, and sympathetic activation is thought to play a big role.
HFpEF is definitely an attractive target for RDN, precisely because our current treatment options are so limited. And yes, autonomic dysfunction is a key feature, but studying RDN and HFpEF has proven really difficult. There was a trial called RDT-PEF that aimed to enroll 50 patients. They actually had to stop enrollment early after getting only 25 patients on board because recruitment was just too slow and challenging. It highlights how complex this patient population is to study.
Wow, only 25 patients, and what did that tiny trial find?
Unfortunately, didn't show any significant benefit. There was no improvement in quality of life scores, exercise capacity, or measures of heart structure compared to the sham group.
So the bottom line for heart failure, both HFrEF and HFpEF, is
The bottom line is RDN remains firmly investigational for heart failure. The theory is good, the preclinical data is suggestive, but we absolutely need results from large, well-designed, properly powered, sham-controlled, randomized trials before we can even think about using it routinely in CHF patients. Those trials are ongoing or planned, but we need the data.
okay, makes sense. Let's look beyond heart failure then, and some of the remaining questions and future directions for RDN in general. You mentioned earlier the lack of reliable predictors for who will respond well, and also this lack of an immediate feedback measure during the procedure itself. That seems like a big practical gap.
It really is. It's quite different from many other catheter-based procedures we do in cardiology. If you put in a new heart valve, like a TAVR, you can immediately see on ultrasound or measure pressures to know it's working. If you're ablating for atrial fibrillation, you can often see the abnormal electrical signals disappear in real time.
But with RDN, you do the ablation, and then you wait.
Hmm.
You don't know right then and there if you've successfully denervated enough.
Pretty much. You finish the procedure, you wake the patient up, and then you wait. Usually weeks or months, to see what happens to their blood pressure. There's no immediate confirmation of success. We don't know definitively, for example, if measuring the electrical impedance change during RF ablation, or maybe even the patient's pain response, reliably correlates with nerve destruction and clinical outcome. Developing some kind of reliable intraprocedural marker of successful denervation would be a huge step forward. It would help optimize the technique, ensure consistency, and maybe even help select patients better.
And the ultimate goal isn't just lower BP numbers. It's preventing heart attacks, strokes, death. But running those huge long-term cardiovascular outcome trials for RDN must be incredibly challenging.
Oh, immensely challenging and expensive. You need thousands of patients followed for many years. There are lots of hurdles. Patients might cross over from the sham group to active treatment if their BP stays high. And paradoxically, because standard medical therapy for hypertension is actually quite good now, the overall event rates in trial populations can be relatively low.
Which means you need even more patients followed for even longer to statistically prove a difference in heart outcomes.
Exactly. It makes definitive outcome trials very difficult and costly to conduct.
But there is some suggestive data from registries, right? Linking BP control after RDN to better outcomes.
Yes, that's an important point. While we wait for definitive outcome trials, registry data provides useful clues. Studies looking at large patient registries have found that achieving better blood pressure control after RDN specifically, spending more time in the target range, is strongly associated with having fewer major cardiovascular events down the line. It strongly suggests that the BP lowering achieved by RDN does translate into meaningful clinical benefit, even if we don't have the final RCT proof yet.
Okay. This leads us to probably the most forward-looking part of the review, the idea of multi-organ denervation. Taking this beyond just the kidneys, what's the thinking here?
This is really pushing the envelope, thinking about the systemic nature of sympathetic overdrive. We know this overdrive isn't just involved in hypertension and heart failure. It's deeply implicated in the whole cluster of cardiometabolic diseases, things like insulin resistance, obesity, type 2 diabetes, even fatty liver disease.
So if the root problem, sympathetic overactivity, affects multiple organ systems, maybe the solution needs to be broader too.
That's the concept. If the sympathetic nervous system is the common driver, maybe we need to modulate it more broadly than just at the kidneys.
And the review specifically mentions targeting the nerves around the hepatic artery, the main artery going to the liver, as the next logical step. Why the liver?
The liver is central to metabolism, especially glucose and lipid control, and its function is heavily influenced by sympathetic nerve signals. There's evidence that excessive sympathetic drive to the liver contributes to problems like insulin resistance and the buildup of fat in the liver. And here's the kicker, anatomically. Studies have shown that the density of sympathetic nerves around the common hepatic artery is actually higher than the nerve density around the renal arteries.
Wow, higher nerve density, so potentially an even bigger target for denervation.
Potentially, yes. So the
Yeah.
idea being explored now is, what if we combine renal denervation with hepatic denervation? You'd target the kidneys to help with blood pressure, fluid balance, and RAAS, and you'd target the liver nerves to potentially improve metabolic control, glucose regulation, lipid profiles.
A two-pronged attack on cardiometabolic disease. Is this actually being tested?
It is. The review mentions pilot studies like the Spiral Gemini trials. They're specifically looking at the feasibility and safety of doing combined renal and hepatic denervation in patients who have both hypertension and related metabolic problems like type 2 diabetes.
That's fascinating. If that pans out, it really shifts RDN from being just a blood pressure procedure to potentially a broader metabolic modulation procedure.
Exactly. It represents a move towards thinking about these interconnected chronic diseases, hypertension, diabetes, obesity, heart failure, kidney disease, not just as separate organ problems, but as manifestations of a common underlying autonomic nervous system dysfunction. And targeting that central driver could be a powerful new strategy. Hashtag tag outro.
Well, this has been a fascinating deep dive, really clarifying where RDN stands today and where it might be heading. Let's quickly recap the main takeaways for everyone listening.
Okay, first takeaway. Renal denervation is now established as a safe and effective adjunctive treatment for uncontrolled hypertension. Its key advantage is that always-on effect, working independently of patient adherence, which is a massive clinical problem. And importantly, this efficacy and safety profile, proven in good sham-controlled trials, has led to its incorporation into major clinical guidelines, particularly in Europe, for specific patient groups.
Right. Second point. For chronic heart failure, the underlying theory for using RDN is really strong, given the role of sympathetic overdrive. However, the clinical evidence from large trials just isn't there yet.
Yeah.
So for CHF, both reduced and preserved ejection fraction, RDN remains investigational. We need more data.
Absolutely. And the final key area is future research. Big focuses are on improving patient selection, figuring out who will respond best, and developing ways to measure procedural success in real time. And then there's that really exciting, potentially game-changing concept of multi-organ denervation, like combining renal and hepatic artery treatment to tackle the broader burden of cardiometabolic disease at its systemic roots.
Which brings us perfectly to our final provocative thought for you, the listener, to chew on. Building right off that multi-organ idea. Given what we know about the deep, undeniable connections between kidney health, heart function, blood pressure, and metabolic diseases like diabetes, how might these kinds of interventional therapies, the ones that precisely target the nervous system signals driving these problems, actually change our whole approach? Could we move away from just managing the failure of individual organs and start thinking about controlling the central systemic drivers of all these chronic conditions together? Something to think about. Thank you for watching The Funnel Effect.